Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features expert answers to your questions from an educational symposium titled Modern Approaches to CMV Prevention in Solid Organ Transplant Recipient, featuring Dr. Atul Humar as the program director and Drs. Hannah Imlay and Raymund Razonable as expert faculty. Dr. Humar is a professor of medicine at the University of Toronto in Ontario, Canada. Dr. Imlay is an associate professor of medicine, part of the Department of Internal Medicine, Division of Infectious Diseases at the University of Utah in Salt Lake City, Utah. Dr. Razonable is a professor of medicine at the Mayo Clinic College of Medicine and Science in Rochester, Minnesota. For the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now let's get started and hear what our expert faculty have to say about this topic.
There's a couple of questions about the whole what's best for liver transplant patients. And you both talked a little bit about the capsule study comparing preemptive versus prophylaxis. And I'm just curious in the real world, because our center uses prophylaxis for liver patients with valganciclovir. And I think most centers actually still do that. And in the real world, where preemptive therapy is logistically quite difficult, and patients often miss the weekly viral load, they might do it the first couple of weeks and then miss a couple of measurements. And so they may develop disease during that time that it's missed. And I'm just wondering if both of you could comment on that. There's a couple of questions.
Yeah. So disclosure, I'm part of the authors on that capsule study that showed that preemptive therapy may be better, at least in preventing CMV disease at 1 year. But again, you mentioned the logistics of doing that. It worked in the clinical trial because we have study coordinators that basically went after patients every week. We need your viral load. We need your viral load. You need your testing. That's difficult to do in real world because many of our transplant coordinators, they're also overworked. So there may be a high chance of missing viral load testing. So despite the result that is showing that preemptive therapy may be better in liver D plus or minus liver D plus or minus recipient, our center is still doing prophylaxis.
And ours is too. Although I would actually like them to switch to PET, and that's been the theme of many discussions over the last few years since the study came out because of the better outcomes. However, it's all about the logistics. And I think the notable part, at least of our program, is that we actually do a hybrid model. So PET after prophylaxis. And we have reasonably good rates of viral load checking in that PET period. And can we shift the work to the early post-transplant period instead of the late transplant period? The stakes are higher for missing viral loads, just like Raymond brought up. Or can we come up with more creative strategies? So something our institution has discussed is creating a collaborative pharmacy agreement so that pharmacists would be the primary monitors of CMV viral load when they're obtained and can have more dedicated resources to that task.
Yeah.
But hasn't happened yet, so we'll see.
Okay, so the next question is more of a practical question. So what are some practical considerations for switching from valganciclovir to letermovir for primary prophylaxis at my institution? Maybe we could just do a quick show of hands. Are there any institutions yet that have already switched to using letermovir prophylaxis for solid organ for kidney transplant? Just raise your hands. Yeah.
Okay.
One. Any institutions that are considering it actively that you know of? So what do you both think? What are the
logistical considerations?
Logistical or other considerations?
It's right.
At our institution, the main consideration
Cost.
is price.
Basically. Cost. Yeah. It's the cost. So our protocols have been updated to include letermovir as the first line, if this is something that is possible for patients. But because of cost consideration, most people are still on valganciclovir. And then the letermovir then works when there are issues with valganciclovir, like when they develop leukopenia and other toxicities, then letermovir comes into play.
And I think for us, yes, exactly the same as what everyone has mentioned. I think also the major reasons to switch to letermovir instead of valganciclovir on a programmatic level is to decrease the toxic effects of your antiviral of choice, which is just as applicable to R+ as it is D+ or minus. However, because R+ is not on the FDA label indication, it's much less likely to be covered by insurance companies for patients who are outpatient at the time of switching. We really haven't made a programmatic decision because it didn't make that much medical sense for us to only be able to switch to the D+ or minus, given the cost considerations and the logistical issues with receiving prior authorizations and switching patients financially feasibly.
Thank you. So the next question, maybe I could answer actually. Does maribavir have a high barrier to resistance? So the answer to that is in the SOLSTICE trial, which Raymond presented, the resistance rate was approximately 26% emergent resistance in the maribavir arm. So it's a fairly high rate of emergent resistance, although remember, this is a very difficult to treat population who typically does develop resistance to whatever antivirals you give them. The clue to, if you're treating somebody with maribavir, if their viral load goes down on maribavir, and then while they're still on maribavir, the viral load goes back up, almost all of them have maribavir resistance, and it's a true resistance mutation with which you can't overcome typically with higher maribavir concentrations. So that about 86% or so will have a mutation if they have that pattern on maribavir treatment.
Agreed.
The next question, is there any fixed duration for CMV treatment, or does it depend on viral load?
Depends on viral load. Hopefully, if you have access to CMV CMI, it also depends on that, as well as, of course, clinical assessment. In the past, we focused mainly on viral load and clinical, but for those that have CMV CMI capability, that's also important to take into consideration for the duration of treatment, as well as possibility of secondary prophylaxis.
I agree with that.
There's a question about using lymphocyte count, and I think we've talked about that as a poor man's cell-mediated immunity.
It's free. Yeah. Oh, no, it's not free, but it's there every day.
Yeah.
The poor man's cell-mediated immunity is subsequent DNA immune.
Yeah.
There's a couple of questions on maybe trying to clarify the threshold for treatment of asymptomatic DNA anemia. Go for it.
It depends on the underlying. So if it's a mismatch, D+ or minus, who has viral load replicating, you know that the patient has no underlying immunity and they are on immunosuppression. Our practice, or my practice, is to treat that regardless of the value. And the clinical trials, the capsule trial actually implemented that, wherein any viral detected in a D+ or minus that was liver or any solid organ transplant recipient needs to be treated. For seropositives, that's where the debate comes. Various assays, various centers, there's really no, just like what Dr. Imlay had said, there's no widely accepted threshold as to when to treat. Some are using 1,000, some are using 5,000, but those are all dependent on the type of assay that they use. So ideally, your center or your program should come up with a threshold that is applicable to most of your patients. And again, I would say that even seropositives, 1,000 in a lung is much more significant than 1,000 in a kidney. So it also varies depending on the organ. Like, for example, 1,000 in a seropositive who had a rejection 2 weeks ago is completely different from 1,000 of the same patient that did not have a rejection. So all of those comes into play as we try to interpret and act on a specific pattern.
And I would say actually even the D+ or minus gets complicated. It's not complicated if it's the first time they've reacted, or if it's the first time they've transmitted and had replication. It becomes much more complicated if, similar to this patient, it's someone who's beyond a year, had it detected incidentally. And so for some of those patients even, we do wind up monitoring because they're very far out from transplant. And the value of starting antiviral therapy in some of those patients is questionable. But I think that's the issue. That's the problem with this whole thing is the appropriate viral load threshold is in the eye of the beholder, which probably also, which rests on really clearly defensible things such as type of organ transplant, serostatus, how far they are out, whether they've had recent rejection, but also probably depends on things that we all experience in medicine, like anchoring biases and confirmation biases and things that day of the week type of stuff.
One other thing that I observed is some people who have chronic symptoms, they don't pay attention to it, like a simple loose stool or something like that. But because they've been doing it for 3 months or so. So they won't volunteer that. So keep on asking, particularly with kind of low viral load, that make sure that there is no GI disease that is unreported.
Thank you very much to our faculty, and thank you to our listeners for joining in. To listen to other episodes from this session on CMV, click on the link in the show notes. And please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.